My name is Melissa Singleton. I'm Chief Programs Officer, and I want to thank you all for making time to be here tonight. In terms of today's objectives, we are going to be really kind of getting into the nuts and bolts. We're describing the functions performed by the front office and back office within a house call program, discussing the various types of professionals who perform those duties in the house call program, and we're going to talk about the people, the processes, and the technologies that can improve your operational workflow and your safety. So again, we hope this will be very interactive and that you can learn from the best practices of our experts, but you can also share with others ideas that you have employed in your own programs. So our speakers, it's my absolute pleasure to introduce our speakers tonight. You're going to hear first from Alicia Bobak. She's a family nurse practitioner and a consultant in physiatry, pain management, palliative care, and wound care. And then we are also joined at the back of the room by Dr. Paul Chang. He's medical director for Northwestern Medicine Home Care Physicians. I always feel like I have to update this number for him because the last time I introduced him, he had done 37,000 house calls in his career, 37,000 to more than 3,600 patients. Have you gone up to 38,000 yet? Okay, so next time I'll have to change the slide. Okay. And and he's, of course, boarded in internal medicine and hospice and palliative medicine. And it's our absolute delight to be able to call him our senior medical and practice advisor at Home Centered Care Institute. So we get to work with him a couple days a week. All right, so at this time, I'm going to welcome up Alicia, and she's going to talk to you about front office and back office staffing and processes. Thank you.
A little bit about myself. Why am I here? Why am I presenting? I have been in the healthcare industry for about 14 years. I started off as a nursing assistant with homebound patients. My first patient, I remember to this day, was a CPD officer who was in a car wreck and was paraplegic. I will never forget him. I learned so much from him, not only as a person, but as a healthcare provider as well. I moved on, became a nurse when I was 20 years old, and I worked for a home health company as well. Then I moved into the hospital. I do like post-acute care, rehab space, learned a little bit of palliative care and hospice. Got my wound care certification. I built a wound care program for house calls, which is much needed, especially in the south suburbs right now. If you guys know the south suburbs region or south side of Chicago, wound care is definitely needed. There's a lack of wound care providers. I did move on to be vice president of operations for a palliative home company through Schaumburg. And we grew that company from 1,000 patients to over 5,000 palliative patients in Illinois, Indiana, Ohio, Pennsylvania, and Michigan. Right now, I did take a step back. I wanted to focus on clinical work as a family nurse practitioner, so I do visit post-acute spaces in the surrounding areas, hoping to start building another home visiting program here in the future. Again, I just want to say thank you for taking out time out of your precious life to join us here and talk about home-based primary care. A lot of knowledge in this room. Force to be reckoned with is what I hear from all of these years of experience, and then individuals who want to start their own practice as well. Welcome. It is hard, and someone did say healthcare is in trouble. I'm not going to disagree with that, but there are some changes that need to be made, shifting from fee-for-service to value-based care. How do we do that? As you guys know, reimbursement rates for providers are low and becoming lower and lower by the day. So how do we adjust with all of our office support, front office and back office, and that's what we're going to talk about today. When you think of a home-based primary care program, there are so many individuals that it takes. This slide is just the beginning of it. We'll go through each one. We'll talk about the front office, the main roles and responsibilities. I did want to get your feedback on here. On the far right, it says dietitian, dentist, optometrist, podiatrist, chaplain, home health, hospice. These are other providers that consult or specialty areas that we can utilize for our patients. Are there any others that come to mind? Maybe patients that you've seen that need a specialty that can't get out to go to the specialty, or any of your patients that currently have other specialists that see them. Can you guys think of any other specialty areas where home-based primary care programs can consult or have visit them as well? I love asking questions and I love being interactive. I just don't want to read off the slide, and you guys have a wealth of knowledge. So
I'm thinking urology.
urology is a huge one. Voiding trials, BPH, hematuria. How often are they going out to there just to get the Foley removed and a scan? We could do that in the home, or we need the specialists. That's a great one.
I know how often Dr. Chang talks about wanting a pharmacist.
Pharmacist is one up and coming. Every program really wants a pharmacist on staff. Why? We want to do polypharmacy. We want to look at all their medications and their side effects. Why is a patient falling 6 times? Are they on a double dose of a medication that they're not supposed to be on? So pharmacists are very integral part. However, when you're first starting, you may not have the financials, or you may not have the patient census for a pharmacy. So what do you do when that happens? If you're looking for support from a pharmacist, any ideas?
Yeah, just a quick comment. Depending on your funding source, I think a pharmacist will be hugely beneficial. We published a study from our practice. The average number of medications our patients take, 17. That's 17. Imagine that. That's just crazy in terms of cost and side effects and drug interactions and all of that. How can a pharmacist help your team? If not, formally, maybe informally, how do you come alongside the patient and family to deprescribe? There's some resistance to deprescribing, right? Whether it's security, whether it's don't rock the boat kind of things. What are some ways that you can broach the subject and help your patients deprescribe or de-escalate the medications that they're on?
For me, the pharmacist is a godsend. Sometimes we'll ask for special formulation. Like this medication, patient, can we have this kind? So normally they will do something for us, like the doctor will say, call the pharmacist. We want to disable the coughing. So they give us medications, or you can use Hycodan, or we want to do this. So like any anxiety medications, patient can swallow, refusing the mouth, so we can have a gel. So that's why we consult the pharmacist that this is the medication that we need. We cannot administer easily.
That's a great one. Pharmacy is definitely one that comes to mind. One that also comes to mind, at least what I see, is dermatology. Wound care also, but dermatology for biopsies. Or a full skin assessment is one as well. I do want to focus on the bottom, the clinical aspect. We have to have providers to see the patient. So physicians, physician assistants, nurse practitioners. Do you have a nurse going out to do visits as well? Patient education, that's typically what they do for their visits, diagnoses, nutrition, care oversight, direct care. That is the foundation. You have to have a provider that has experience. I can't stress that enough. We do hire new grads. However, they have to think outside of the box. When you're in the hospital setting, they have a charge nurse to go to or a specialist on hand. When you're in the home by yourself, you can call your collaborating physician. However, that provider that's in there really has to do a full assessment not only of the patient, but the home. Like Dr. Chang was saying, looking in the fridge, looking at their medication bottles. Do they have pets? Do they have any family that's coming to help them? Have they been in bed soaking wet for 5 days when they're supposed to have a caregiver? Those are the things that the providers need to look at and assess that's different than the hospital or clinic-based setting. Second, who's going to support these providers? Who's doing their scheduling? Who is doing the billing, the coding, obtaining medical records, intake? That is practice management. So if you're thinking about going into a home visiting program, you have to think about that as you build your census. When is the right time to hire support for yourself and your providers? And also we have social services. Social determinants of health is number one right now. We're looking at EHRs. How are you inputting that? There are going to be key metrics in 2024 that they're looking for each patient. Who can do that assessment? Social workers. Social workers are a great tool to have on staff, not only for social determinant of health assessments, but they can also do case management. They can also do therapy. You can bill and code for therapy for a licensed clinical social worker, for depression, adjustment disorder, things like that. What is nice to have a social worker on for is for the community resources. So your providers may not have enough time with the patient to get everything coordinated. Food. What if they need food? I don't know where to go in specific towns and areas or who to call, but I could tell you my social worker does in every county. So it's a great resource to have with a home visiting program. Now, looking at these different roles and responsibilities, are there any ones that can be combined? As you're starting a home visiting program, you will have to combine roles and responsibilities to improve efficiency, and you may not have that census to support that new hire as well. So out of all of these roles and responsibilities, is there anything that can be combined?
In ours, in hospice, the social worker is part of our team. So they're considered LCSW. They're considered as clinical too.
Correct. They are clinical. In our eyes, in my eyes, the social worker is really spearheading that case management, behavioral issues, in the home. This is home setting.
Okay.
Typically, they need resources in the community, and that's where the social worker really shows, their expertise. Any guesses on what roles can be combined? Thoughts? If you were just opening up a practice, who would you have do the social worker aspect? Say if you just had like a practice manager, a medical assistant, typically we would combine. So if I had a low census or starting a program, I would have a nurse, and that nurse would actually act as the social worker finding community resources. So as that census builds up, then we can hire that social worker. So just thinking of roles and responsibilities and utilizing those individuals to their highest role within their certification. And nurses can definitely coordinate care and find resources in the community. We're going to move on to the front office, briefly touch on some main roles and responsibilities. First, incoming and outgoing phone calls, initiating and routing messages as appropriate. In some programs, this can be a medical assistant that's office-based, or it can be a medical assistant that is home-based. You have the calls rerouted to them. They're at home actually answering the phone calls. If you wanted it to be a nurse, that's okay. We just want to make sure that the nurse is answering the clinical calls. So typically this can be a clinical coordinator, a nurse navigator. There's a lot of different terms that organizations can use for the incoming phone calls and triaging. Who's going to do the insurance verification and intake? If you have a home health calling you and saying, I have this new patient, who's obtaining all that information? Is it the person answering the phone call? Do you have an intake specialist? Is it the medical assistant? And are they trained on intake? Are they looking for the exact things that they need to bill accordingly and properly? How are you conducting new patient intake? Do you have a form? Is it in your EHR? Are you updating it? Are you looking at regulations? Who is doing all of that? Paperwork and form management. Are you still writing on paper? Or you have paper charts, medical records? Everything needs to be in the EHR. Who's uploading all of those documents? Who's uploading all the signed documents from the providers? Those are just things that we have to work through, and those tasks take time. So when you have a front office, really identifying what they do and how long that they're doing each task to see how their day can be efficient. Who's doing the scheduling? Are the providers doing the scheduling? Most likely no. You have office support, medical assistants that are doing the scheduling. How are they doing the scheduling? Are they utilizing MapQuest? Are they utilizing high technology nowadays that they have to decrease drive time. And we'll get into geographic scheduling here in detail because that is the number one question providers have when you are onboarding or even interviewing. What is my range? How far am I driving? How do you prevent burnout from driving? What territories do I go to? Who plans those routes? Yes, they could put it into a system, but who's calling those patients and confirming? What if a patient cancels? Can we add another one? Appointment confirmation. Are we calling 24 hours before to confirm? A week before? A lot of the patients do end up going to the hospital. They want to cancel a visit if they're sick. How are we documenting that and who is calling them? Medical record requests is a huge one, especially if you're ordering home health. They will keep calling and calling until something is signed or records are faxed over. And it can be tedious. You have to look in the EHR, you have to save each progress note, results, fax it back. And then assistance with practice billing and coding, if applicable. Some practices choose the provider to code. Some, the EHR does the coding for you. Some have a billing and coding specialist in-house that codes based on documentation or a third party. So there's a few options for billing and coding, and we'll also get into that. If you are a bigger practice and are looking to do chronic care management, remote patient monitoring, are you having that in-house? Are you outsourcing? What is the cost analysis on bringing that in-house? Are you going to benefit from that? And that's a whole different ballgame. Chronic care management, remote patient monitoring, definitely in a microscope right now, making sure everything's documented correctly. Is there any roles and responsibilities in your guys' practice besides these that are listed that you can think of, that your staff or you may do on a day-to-day? Dr. Chang?
Yeah, just a comment about geographic scheduling. I think that's, as Alicia said, is going to be a huge piece of what you do because of, well, obvious reasons, efficiency. Who's going to do it? In my office, my front office staff does that. What is the staffing going to look like for your practice? There's one provider, she knows her patients, she knows the area so well, she does her own. Mm-hmm. She does not want to use any mapping software. Her software is right up here in her brain. So she does her own. So there's a one-off on that. So will you be able to accommodate a provider like that who's able to do the scheduling kind of on her own, in addition to your other providers who uses the front office to schedule? One last thing, it is very time consuming because of cancellations, because somebody's in the hospital, because somebody needs to be squeezed in for transitional care. As we venture into value-based care, right, is no longer just about volume, it's about access. Right service at the right time, right? So how are you gonna, Alicia will talk more about urgent visits later on. How are you gonna accommodate that? One final comment is about billing and coding. We do have a webinar coming in January. There's some changes to the physician fee schedule for Medicare 2024. There's some downer news, but there are some opportunities for us to gain some of that revenue back. So join us in January for our webinar.
Thank you, Dr. Chang. It did jog my memory as well for these front office staff individuals. What are their hours going to be? If you're 24/7, if you're saying you're open 24/7 or the patient can access someone 24/7, who's going to be on call after they're not there to answer the phone? Are you outsourcing to a third party? We did in the beginning. It was great. But we wanted to have some key metrics and really have everything in-house. So we brought that internally. But you have to do a cost analysis to see how much are medical assistants being paid right now. After, I think they're up to $22 right now. So if a average reimbursement for a physician, nurse practitioner, or physician assistant, I think in 2021 was $85, you got to pay the physician or the provider first. The rest goes to the office staff. So making sure your numbers are correct as far as how much office staff you need per provider. How does that come about? The provider census. That number is going to guide everything. If you have a full-time provider, part-time provider, PRN provider, what number do they need to have their own case manager? What number of patients do they need to have a nurse? The goal is to break even in home primary-based care. I've been with 2 companies. They did make money, which was great. However, we know reimbursement in 2024. With what I'm seeing, it's going lower, even lower. So we need to be strategic in hiring our support staff. But we also, it's a teeter-totter, we also need to support the providers. They can't be doing everything. They need to focus on patient care and assessments. Back office. The provider goes to the home. They're ordering medical equipment, labs, x-ray, ultrasound, consultants. Who are all those orders going to? Are they faxing the orders? No, we need back office support. Does the back office support individuals understand what is necessary for those orders? Is it a nurse doing it? For medical equipment, do you have a specific company that you're ordering through? Or are you ordering through multiple companies? Each company, they have a different form. They need different things for certain equipment. Is it covered? Who's going to communicate with the patient? They had a wheelchair ready 3 years ago. They can't get another one. They have to pay out of pocket. Who's coordinating all of these orders for the provider? That's the back office role. Prior authorizations is another one. Very time-consuming, tedious. They typically want to talk to the provider. And we can't be on the phone for an hour at a time trying to get a prior auth on a medication or equipment. Who's going to be doing that? Who has the clinical knowledge? Typically a nurse would assist with this role and responsibility. Prescription refills. Are your patients calling you 24/7 for medication refills? Is the pharmacy faxing you over and over again for medication refills? Do you set aside time for your providers, an hour at the end of the day, to fill medication refills? Or do you have a nurse accepting the medication refills after they're reviewing the chart? They may know the patient, and you're okay with them hitting that button in the EHR. Liaison between community services and provider, I touched on that. Typically, if you have a social worker within the organization, they can assist with that, but if you don't, who is going to do that? You have to be familiar with community resources. Each county is different. Each county has different rules and regulations on what's covered and what's not covered and what resources are out there. A patient on the south side of Chicago, you may be looking for a nutritionist or a wound care specialist. Guess what? Maybe they don't have anyone for a month. What are you going to do if that wound is deteriorating? But on the north side, you may have more wound care providers. So it's about knowing your territory, knowing your regions, and where you're expanding as well. Inventory management for providers. Are you guys using your own equipment? Are you buying it? Are they a W-2 employee? Are they a 1099? How are you compensating for inventory, for supplies? Typically, a provider may have a bag. They need gauze, just basic necessities, stethoscope, blood pressure cuff. How are you keeping inventory on that? What if a new provider is saying every month, I'm misplacing my blood pressure monitor? Well, keep it in your car, take it with the patient, make sure you put it in the bag. It adds up. Every little dollar adds up. Care coordination, who's obtaining and documenting medical history? Incoming phone call, new referral, rapid admission, you want to see within 24 hours. Where are we getting the history from? Are they sending it to us with their referral? We would love that so we could review it before we walk in. But unfortunately, I would say 50-50. They're not sending anything. You don't have any history. You have to request the history. Technology is improving where you can log in and get the history from different hospital settings, which is nice. You could review everything. What if the patient has dementia? Caregivers there doesn't really know the history, doesn't have a POA. We do our best in each scenario as providers to obtain the history, but we still need some support from the family. Call patients with results and medical advice. I would love to hear in some of the practices what you guys are doing for results that are coming back that may prompt a visit or an immediate phone call. Are the providers calling? Are the nurses calling? Are you scheduling a visit within the next 48 hours to discuss? I would love to hear some of what the practices are doing right now. Because this is a big one. It takes a lot of time to educate them on labs that are not in the norm, or you may need to adjust the medication. Are you calling the patient, doing a telehealth, billing them? Or are you having a nurse or a medical assistant call them and explain it to them?
I've been in private practice for almost 20 years before I joined a very large healthcare system. In private practice, we had literally minimal support. Our office manager was everything. So we just very efficient practice, basically. And when I come into a large organization, the story is very different. What I found out for myself, it's easier for me to take all the calls rather than somebody unqualified answer the calls, and I have to fix what they did. But my partners were doing perfectly fine with that. So it depends on the personal preference of a provider, and it's certainly more efficient, especially in a large organization, if people do it the same way. But it's hard to achieve.
Like when I go see my PCP, he wants me to get the blood test before I go see him. So he's got the results. He can review with me when I'm there. So that is his way of cutting down phone calls and so forth. So for your organization, big, small, think about the process that you need to develop in terms of getting the blood. Is it going to be internal, or is it going to be an external service? And who's going to call with the results and so forth? Getting back to the phone calls and getting medical advice. A few months ago, I was really getting tired. I was just like, is it just me, the gray hair, getting old kind of stuff? Or is it work fatigue? So I had my practice manager run some numbers for me. Now, my patient panel size is about 250, all right? And in average, for the 3 months that we analyzed the data, the number of in-basket message was over 1,000. Okay, so compare that to Dr. XYZ down the road, who is also in primary care, was a panel of 2,500, 3,000 patients. We had roughly the same number of in-basket messages. I'm 1/10 of his size. So as you are thinking about your program, thinking about how staff, Alicia's talking about the front office, the back office, and think about your budget. You need to rationally staff it with some of the numbers that we're giving you and the needs that your patients have. It's a lot of work, and about 2/3 of my in-baskets are what? Are they MyChart messages? No, they're what? So staffing and billing are a consideration when you're talking about time.
I think one consideration, when we're returning, calls and communication in general, I think, and you will probably go into this, is how do we use AI? How do we use technology in order to, do that without creating anxiety for the patient? Because sometimes if they see that, oh, my TSH is off, what does that mean? Oh my God, my mammogram, what does that mean? I have to do an ultrasound. It can be very anxiety provoking. So that timing of when you give the information is important. So if it's non-urgent and it's not something that's going to create anxiety, I think it's okay to share that on MyChart, et cetera. I love seeing it because I just love having everything because I know how to interpret it, right? But for some patients, it can be bad. The other thing is to communicate back with them. Should we be using these platforms to make it more efficient? Sometimes that can be done. It depends, I think, on what the patient wants. But at my company, we use a lot of audio messages, which cuts down a lot of time of being on the phone. So you're sending a message and it's an audio, but it needs to be encrypted if you're giving medical information. And obviously there needs to be a disclaimer, but that can be just sufficient. And if they have further questions, they can call back. So there's a lot of avenues that we can consider.
AI is going to be a big part of our future. For example, Alicia talked about billing and coding. Dana and I met this particular company when we were at an academy meeting a few months ago. It's AI-powered billing and coding. Imagine that. Of course, it's going to cost you money. Again, this, as you're thinking about your business, What can you support? What can you do in-house? Are you going to train your own providers? Join us for a webinar, or are you going to send it out to an AI-powered billing service? One final comment is about AI and about you mentioned prior authorizations. There are prior authorization letters. I'm a routine user of Doximity. No, I don't own any stocks or want you to buy any, but they have Doximity ChatGPT that can help you with appeal letters. So keep that in mind as a way to cut down on your work.
So it depends on what platform you use. If you have an iPhone, you just click the plus sign right when you're sending a text message, and you can say audio, and you can send it to groups, or you can send it to just the person, and you just talk into your phone, and then they get it as an audio while they're driving. Then at their convenience, they can listen to it, and it can be a very focused conversation instead of, hi, how are you? And then it takes time to have a conversation. It's just quicker. So you can do that on other platforms too, like WhatsApp, etc. But I think if it's patient information, it needs to be encrypted, and it has to be HIPAA compliant.
We did talk about the roles and responsibilities of the front and back office. These are just, like I said, a few examples. You might hear patient service rep, clinical coordinator, case manager, medical assistant, care navigator, nurse navigator. There's so many different terms for different organizations. So it's important for your organization or home care organization to outline their specific roles and responsibilities. Because they can be assisting with other roles and responsibilities, you do not want to mix that. And when we're talking about KPIs, OPIs, making sure each person is hitting a certain responsibility and being efficient, we need to outline this for all of the colleagues and for the office staff. So patient service rep, they can be scheduling and confirming the appointments while creating provider routes, while handling paperwork, while handling phone calls. A lot of tasks at once, but it's the most efficient. They can do it, but it has to be feasible for them in an 8-hour day. You have to be respectful of their time. They should be getting lunch as well. We don't want to work them to where they want to resign, but we need to be just thinking in the back of our minds, what can they handle within their 8-hour day? And how do you break that up, each task? Medical assistant, are they driving the providers? If they are they triaging incoming calls? Are they assisting in visits? Are they preparing the provider? Are they assisting the provider? For those practices who are still using medical assistants to drive the providers, I commend you. Every organization that had medical assistants within the last 5 years, when we did a P&L and cost analysis, you lose money on medical assistants that just drive the providers and assist providers. So they have to be doing other tasks. They have to be efficient. Otherwise, do we really need them? Can the providers drive on their own, utilizing correct scheduling platforms for more efficient routes? That's a big topic from past, because typically all the organizations do have the medical assistants driving around in cars with the logo. I had one when I was a new grad. It was amazing. But when I looked at it, maybe I want the extra $5 to drive myself, and I can handle the calls, calling the patient. I can handle the vital signs. So it's just things that you have to take into consideration with the medical assistant and drivers. RNs, nurses, case management, relieving that provider burden. We want to get as many tasks away from the providers as they're doing the assessments and handling patient care. They do have a higher level of clinical scope, so if they can interpret some labs, they can call patients with urine analysis and culture results. If you have protocols set, do you have a UTI protocol? Urine analysis comes back, culture and sensitivity comes back. You have a protocol saying if this happens, this is what the patient gets. You could call it into the pharmacy. Is that something that practices have? I've seen practices have that. That's something that you guys would need to decide. There's also other protocols that you can handle as well. Care coordination, patients being discharged home from the hospital. Who's obtaining why the patient went to the hospital, reviewing the discharge summary, prepping it for the provider. A nurse can also do that and provide a report to the provider. Care navigators, LPNs. I love LPNs. We utilize LPNs a lot in front and back office support. They can assume multiple roles. They also have that clinical background. When we had a small practice, we used the LPN for everything. Scheduling, reviewing results, calling the patient with the results, chronic care management, remote patient monitoring. You want to utilize them to their highest degree. Nursing assistants as well, CNAs, they have a background. I would love to hear from you guys if you have any medical assistants or nurses in your office or thinking about having a medical assistant or a nurse in the office, and maybe what you would utilize them for, or maybe why you wouldn't utilize a medical assistant or a nurse in specific roles and responsibilities.
Not medical assistants, but we have LPNs and RNs. So my LPN team is we're in a large practice. So the LPN team is my care coordination team, and they are my backbone.
Everything?
Yeah, they do everything. They do the triaging, they do call-in patients, they do all the logistics with vendors. We do, the x-rays at home, labs at home, they do all that. Setting up transportation, prior auths. What else? I feel like they do so much more. Am I missing anything? Tracking patients, yeah, they track discharge it, pausing episodes. They also, one of the big things they do is, since we are in a large practice, we, have the Epic EHR system with the in baskets. Each provider has their own provider pool in baskets, so a lot of the providers in baskets go to the care coordinator and they decide, they kind of triage it. Is it something they can handle, or does it have to, can an RN do it, or does it have to go to the provider? So they do a lot of that stuff too. But yeah, so that's how we use our LPNs.
No, I'm listening, and I heard you in the beginning. You said you're lucky to break even in a house call practice, and I agree with you. What I don't, we don't have an RN. We have a medical assistant. RNs can work where they want, when they want. They interview us. Is there a sign-on bonus? Relocation expense? Tuition reimbursement? How much PTO? And I know you were mentioning your RNs do a lot, which is great. You have the luxury of having them on salary, but some of the stuff I'm hearing that the RN is doing, I would think a clerical worker could do at half the price.
That was the LPN that did that, not the RN.
Okay. But you know what I mean in terms of paperwork or intake or obviously for triage, no, but the lab results or medical records, and I would think a social worker might be more cost effective than an RN. They don't command the salary. You can also bill for a social worker visit, and they tell them what services are available, how to obtain them. With an RN, unless you're a home health agency, I don't know. To me, it's just a big cost.
You hit it on the nail. I will tell you, with one organization that unfortunately, they had to close down their palliative care program, home visiting program, they were over budget. They had a provider with 200 patients, a case manager assigned to them that was a medical assistant, an LPN or a nurse that was their clinical coordinator, and a social worker. So that kind of, went down. When they switched the nurse with a social worker, they broke even because you can bill. They can do multiple hats. So things like that, yes. But nurses, LPNs, they do have a role in home visiting programs, I will say. But it comes down to census and what you have assigned to each provider.
I'm supported by a health system, so compared to others who are startups or one or two person, one or two person show, it's much more difficult to support a medical assistant than being in a health system like myself and another organization that ACCI is working with. I've been spoiled. I go out with a medical assistant. Yes, I've done it both ways, but it's obviously a lot more difficult when I'm out alone. Just like yesterday, it went so smoothly. with my medical assistant. I call it a dance because we know each other so very well. We worked 3+ years. She knows when I'm stopping to talk, and I know when she stopped talking, and we know our roles going into the visit. So it's hard for me to imagine without a medical assistant, but that's just me. Other practices use medical assistant to remote room patient. So they call the patient, get the charts going, and they get ask some basic questions, go over the medications and so on, and they room the patients for the provider that way from a central office, so they can room multiple patients. No, they can room multiple providers rather than just being stuck, if you want to call it that, with one. So those are just different models. One last comment, people ask me what keeps me awake at night, and that's staffing. Not only are we competing with other health systems against each other, right? We're competing with non-traditional services now. Amazon, a bus driver, $26 an hour, advertised down the street from my house. So do you do market analysis? How much are you paying your medical assistants or nurses? So for me, it's staffing that keeps me awake.
I mean, I think strategically, as a small practice, I think you have to go bare bones to make any money. To be honest with you, I don't see any money in there. It's all wonderful having all this stuff, and that's what we're planning to have because we're counting on value-based money. Because we're not gonna make money. We're gonna lose money up front. We're gonna collect it all in the back. Just managing population well, because our community, we have to take care of it one way or the other. I really, to be honest, it's if I had to build a practice, and like I said, I've been doing it for 20 years. Math does not add up, and they keep cutting and cutting and cutting, and the costs keep going up. You got to find other sources of revenue rather than direct fee for service. So,
Absolutely.
and I think that's what you're, I think the next in March, right? That's the one. You have to be part of value based.
Yeah. So yes, join us next in March to talk about value based as we are all transitioning. Yes, even Northwestern, the slow moving health system is transitioning to a value based program. So join us, and also join us. I think in a week, Melissa, she's not here. Oh, there she is. We're going to talk about data. Data is going to be so important. I know that's not the topic of our session today, but data is huge. When you are talking to a payer, demonstrating your value, and so forth. Join us for that regarding the importance of the importance of having the right information for not only showing your worth but also clinical, right? So I'll just leave it at that.
And I will say switching from fee-for-service to value-based is a team effort. It's a lot of work. It's very hard. I was part of an organization where we were 100% fee-for-service. We flipped it to value-based within 8 months, and then we were part of an ACO REACH. So there are data points that they will talk about with data analytics on what exactly that they're looking for, rehospitalization rates, deaths on service, money spent, so all of that is we take into consideration as well. Process development. If you are just starting out with a home care program or part of a big organization, these are the things that we look at every day, every quarter, every year. Your intake department. Who's doing that? You need to define eligibility and discharge protocols. Are you discharging patients that are not answering their door? Are we wasting the provider's time if they try 3 times? Are you going to discharge that patient? What's the protocol on that? Patient dismissal and no-show policies. Are you charging them for not answering their door and not answering when they were confirmed? We did. $20.
Did you collect?
We collected. We collected. Patient dismissal. Are they compliant in your treatment plan? Do you have them for pain management? Are you dispensing narcotics? Are you signing a pain consent? Are they requesting pain medications too early? Are they selling those pain medications to the neighbor? We all know those patients. Are we discharging those patients appropriately and documenting just in case there is something legal that comes up? A lot of discharging patients in home care, they try to switch from company to company to company. A provider says, no, I'm not dispensing a medication till I get labs. They're refusing the labs. They're going to cancel your service, move on to the next one. How do you handle those patients? Do you try again? Do you try to get their POA or family involved to see the root of the problem? Geography, scheduling process, we will get into as well. Triaging protocols. Patient that has been on your service for 3 years calls in. They think they have a UTI, family's saying they're a little confused. How are you getting them in for a visit? Who's the closest provider? Are they gonna go see that patient? Is it an add-on? Are you doing telehealth? I will say, when we did have medical assistants, we would actually send some of them out to get the telehealth with the patient, and the provider in between visits, that's driving with another medical assistant, they would telehealth in between. So they would be in-person visits and then telehealth during the drive to the next one for those urgent cases. Urgent visit protocols, inventory management, we touched on that. Bed bugs and infection control, huge one. What's your protocol on that? Provider goes, first patient, bed bugs. They're supposed to be seeing a patient that's immunocompromised with a wound. Is that provider going to that patient? Are they going home to change, shower? What if you know that a patient has bed bugs? Are you leaving them for the last visit? That's what we would do. We would not see them just because they had bed bugs. We would get social services, social worker involved. We'll get that cleaned up, but we still go see them. Do you have PPE in the cars? How is the provider safety, and how are they going in? COVID, huge one. Are your providers seeing COVID patients? What's your protocol on patient goes to a COVID patient, then they're going to the next? Do they have proper PPE? Are they being safe? Dr. Chang, I know, probably has some insight on bed bugs, or...
I just saw one on Monday, a patient with bed bugs. You're absolutely right. Should I make him first or last? Right? Typically, we make them last for obvious reasons that Alicia talked about. But this patient, this gets into scheduling, okay? And changing and geographic scheduling here coming up, because this patient needed a drug trough level. He had to be first. Mm-hmm. How do I deal with that? Okay, what are some strategies I can use to mitigate my risk of transmitting bed bugs to my other patients? And COVID obviously has changed our mindset on everything, right? Who orders the PPEs? Do you have PPEs? When you're making the outbound calls, who's making the calls? And are you doing flu-like symptom screening? When you make those, what is your protocol and who's gonna make? So a lot of things for everyone to think about, whether you're big or small, startup or established. Who's making the calls? Do you have the protocols for this, that, for infection control, and so forth? But this is real stuff. So this is not esoteric just on the slide.
I remember when I was a new grad, and I worked for a small mom and pop home visiting company. I was proud. I wanted to wear my white jacket. I wore business professional clothes. These shoes, not these shoes, but similar shoes. Open back. No. Next day, scrubs. Change in the garage. You know, how are you going to educate new providers coming on? Are you offering them one set of scrubs, or they have to buy it on their own as a part of your onboarding process? Small things like that make a huge difference when onboarding a new provider, and education through their orientation. Emergency preparedness and safety plans, we will get into detail with that. Safety is number one for providers and medical assistants going out in the community. Doesn't matter where. Obviously, we know some communities, you may be at more risk, but they're going out to an unfamiliar territory. You don't know who's in the home, what's in the home, how the patient's going to react, how the family's going to react. New grad as well. Walked into a patient's home, wheelchair bound, had a medical assistant. Her daughter had some type of psychiatric disorder, mental health issues. I always was taught to stand by the door. Don't go too far in. If they're in a bed, of course, you have to go in the back, in the bedroom. My medical assistant went in the back. Patient was by me. Daughter came out, headlocked her. What do you do? What do you do? Fortunately, the medical assistant was able to get away from her and go outside. We did end up calling 911. The patient's daughter ended up going to a mental health facility for a few months, but you don't know. So being aware of your surroundings, going to specific communities in the morning, geographic scheduling. I would go to south side of Chicago in the morning, drive to the north side in the afternoon, evening. You have to teach the providers to be smart and aware of their surroundings, to not be comfortable. You could have a patient for 10, 15 years. You don't know what you're walking into. Safety is also number one for our organization. If a provider feels safe at any time, they can leave. Our patients know that. We tell them on our initial visit and when they schedule. If our providers feel unsafe, they can leave. We will follow up with a telehealth visit or a phone call. Safety is number one. Audit policies and documentation standards. Who's reviewing the provider's charts or your LPN's documentation in the EHR? Is it up to the standards and regulations? How are you training them on documentation? Is it a template? Is it copy and paste? Patient collections and financial assistance policy. With our group of vulnerable patients in the community, they often cannot pay their co-pays. They won't pay for the visit. How are you handling those? Do you have protocols for that? Do you have it in your initial handbook that you provide them or in their folder? Are they signing something? Are you educating them on your policies and procedures? Or are you just handing them a folder with vital signs and how to contact you? That initial visit is crucial to go over everything for your practice so you are covered and it's documented. Compliance program and plan as well. We touched on some of these, so I'll probably go through these a little quick just for time. Intake is key for creating an effective intake process. Is crucial to maintaining a solid revenue cycle. If you do not have the patient's correct information and you go to bill, it's going to decline. Who's following up on that? Do you have AR? It's a whole process. Have you been doing home visits for 20 years and you think the patient's address is correct and maybe intake or when they're calling to schedule the medical assistant didn't verify address and they moved and you went there and they're not there? You just wasted maybe 30 minutes driving to the patient's house when all you had to do was verify that address. Intake screens within the EHR, the robust EHRs have those. They have specific areas that you need to meet or you can't move on to the next screen. Date of birth, insurance information, all of that. And sometimes it's actually incorporating the social determinants of health questionnaire in that. Some of the robust EHRs, NextGen is one of them. I used it for 5 years. They're integrating that with the intake process because 2024 value-based medicine, those KPIs are going to be important.
Comment about having a robust EHR. We use Epic, and it's got its quirks. For example, the billing address is the permanent address. So when somebody changes in Epic, the address is the daughter on the other side of town. Okay, so just for those of you using Epic or these robust EHR, just keep that in mind. Is not completely satisfactory sometimes.
Information that you can collect in advance prior to the visit that the provider may need to know, the chart will need to say it from the medical assistant or the LPN. When was the last time you saw your primary care provider? Another question I always ask, are you seeing another in-home visiting provider? It happens often. A lot more. I mean, I'm sure you guys see it a lot more than you guys think. Because like I said, those patients tend to shop around if they're not liking the care that they're receiving or they're not liking the answers. Are there any specific needs or concerns you want to address a visit? Is it the initial visit? Do you have an initial template for your providers? Is it a follow-up visit? What are you following up for? Is it an urgent sick visit? Is it an annual wellness visit? All templates for each of those types of visits and documented in the EHR. Have you been to the ER? My go-to, have you been in the ER? Have you been in the hospital? Have you had any falls? First 3 questions when I walk in. My patients that have known me, they say, no, 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 right away. Those are the ones that you really want to address. And then if they say yes, obviously you want to get that discharge information, discharge summary, what happened when they fell, did they go to the ER, etc. Why did they fall? You're in the home. Do they have any rugs? Do they have any wires that need to just be taped to the ground? Are there members or caregivers who are involved in your care? Healthcare power of attorney, neighbor, daughter, sister. Do they live close? Are they in another state or city? Do you want us to communicate with them after each visit? How do you want us to communicate with them? A lot of the EHRs have this in the intake process, who you want to communicate and how to communicate. Healthcare power of attorney is another one. A lot of these patients, when you first see them, don't have a healthcare power of attorney. Do their POA, do their living will, bill for that. Do you have any other in-home providers? Home health is a huge one. Home healths need to be notified if you're coming in. So those documents can come to you. You need to sign the 485s on time. They'll be calling. Hospice. Are they on hospice? What is your role? If you're an in-home physician, you have a new consult. You walk in and they have a hospice company. Are they using the hospice physician? Are you going to be on as their primary? Those are decisions the patient needs to make. Primary contact and confirm number for appointments, huge. Their phone numbers tend to change a lot, or their cell phones aren't in service. So we have to get a hold of them. When we schedule, we typically say we will not come unless they're confirmed. So on our routes, we will say confirm. That means they confirm 24 hours before that they're home and they're ready for that visit. I will drive to your house and see you. Unconfirmed, and I'm calling them and they're not answering, I am not going. Why? Because 80% of the time, they're not home. Triaging protocols, touched on it as well. We want to relieve any burden for the providers. Urinary symptoms, I touched on UTI. PTOT speech requests, patient calls into the office. They want physical therapy. I'm a physiatrist. Why do they want physical therapy? Do they qualify for physical therapy? Can you get a visit with the provider to see why they need physical therapy? Can you do a telehealth visit? Home health services, continuation or follow-up orders. Typically the home healths are really good about calling the offices on when they need something. Medication refills, huge one. Is it a narcotic? Is it a non-narcotic? Are they actually due for their narcotic medications? Are your providers checking Illinois PMP? Are they just refilling the narcotics because they've had them for 10 years? Wound care. Touched on it. I'm wound care certified. I'll preach it all day. There's not enough wound care providers in the community to do debridement. It's key. We have bedbound patients. They're bound to get pressure injuries. How are we treating it? Are your providers educated on how to treat wounds? Basic wounds, diabetic foot ulcers, venous ulcers, stage 1, 2, 3, 4, pressure injuries. Is there a family that can assist with wound care? Home health nurses go out twice a week, sometimes 3 times a week to help with wounds. What about the other days that need to be changed? Do they need a higher level of care? Do they need to go into a skilled nursing facility for a short term to get that wound healed quick and get on home? Sometimes.
Regarding how is the call handled, refills, ordering of labs, and so on, so that there's not this constant back and forth between your nurse and yourself in terms of ordering. So have a protocol in place. The other is the importance of having medical records. These patients are sick and complex. When you go see them, we use Epic, so we get a lot of. Most of our patients are within the Northwestern system, so we see their labs, we see the notes, we know what they had done and what follow-up that's necessary. That's not true for all of you guys. So how are you going to get the information through the health exchange? What follow-up does the patient need? That's something for you to consider as well. Regarding the confirmation thing, that's something, again, for you and your practice to decide. So there are some patients, I know she's home. She can't hear the phone. She's not going to answer the phone because she thinks it's a spam call. I'm going to go there. All right. So again, I think the policy for the most part is that if we don't get a confirmation, we're not going to go. But how's that message going to get to the providers? Will Alicia have the final say on that? Because she knows Betty's home. She knows her. She's going to say, I'm going to go there. So how are you going to route the unconfirmed phone calls to the provider? Is that something you want to do? Or are you just going to say unilaterally as a practice, say, if it's not confirmed, I'm not showing? There's a frustration with the robust EHR. That's the My Chart message. And these patients are slotted in the calendar, like from 8 till 10 and whatever. But the robust EHR doesn't know that we are doing geographic scheduling, okay? So they will call and say, hey, in my chart, it says 8 o'clock, where are you? And we have to remind, okay, this is labor-intensive work, right? Remember we called you the other day, we told you don't go by my chart, blah, 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 okay? So that's my front office. Now, if one of my APNs, she's doing her own scheduling, she's calling. Okay, is that working at top of license? This is for your internal team to discuss who's going to make the calls, what's going to be the protocol, confirm, not confirm, what is going to be your scripting when you call. Don't go by, my chart schedule, it's wrong. Epic is hopefully coming up with a fix. They're going to hopefully release a home care module. I had a discussion with them a few months ago, so I'm keeping my fingers crossed. Like, hopefully, they will allow us. So hopefully they will have the flexibility of adjusting the time in my chart.
I will say smaller organizations, we did have medical assistants calling to confirm. Bigger organizations, there are technologies out there that could text, leave a voicemail that medical assistants use. I'm not endorsing, but Luma is one of them if you want to look them up on LinkedIn. They're up and coming specifically for home visiting programs as well. I worked pretty closely with them. Geographic scheduling considerations, territory zones. How far are your providers driving? 20 miles, 10 miles, 40 miles, 60 miles? That's something that you guys will have to address as far as where you're accepting patients. When you're going into a new county, are you maxed out on census in one county? Do you need a new provider? Part-time, full-time, PRN? When we were building the palliative program, if we hit a census of XYZ in one county, that's when we would start hiring for another full-time provider. By the time you interview, onboard, train, they're up and running, we have referrals waiting for them. So that time frame is very important too. Are you accepting a patient in 2 counties over to appease maybe a home health that you guys are really close with? You just open a can of worms because they're going to want to send more and more and more, and your provider's driving more and more and more. So really having those boundaries and marking that on your marketing materials and telling home health companies and hospitals where specifically you are providing care. Developing a schedule guide for each provider. What days are they working? What hours are they working? Home visiting groups. When you are hiring providers, that's how we get them in, flexibility. You could start after you drop off your kid at school, go to your patients. If you have to go to an appointment, you can be done a little early, as long as you see your patients and you start early. Are your business hours 8 to 5? Are your providers going out 8 to 5? Or are they going 8 to 8? How many patients are they seeing a day? What's the magic number? I'll let you know a hint. Palliative care, it's 7. You have to see 7 patients for palliative care per day to break even. Primary care is a little different. You could see more. Palliative care takes a long time for visits. You're talking about end-of-life conversations, getting the POA involved, talking to specialists. For our organization, our primary care providers, we're seeing 10 to 12 patients per day. But they had close range. They are not driving far. Does your provider live in a certain area? Strategically posting when you're hiring in specific towns. If I need a provider in Crystal Lake, because we have a source coming in from nursing homes or hospitals, you bet I'm putting out that hiring for Crystal Lake. Not anywhere else. Maintain patient lists from facilities, huge. I didn't realize how big this was until I was in the post-acute space. Those skilled nursing facilities, assisted living facilities, they look for KPIs. How often are you seeing your patients? How fast can you get to my patient if I discharge them today? What's your rehospitalization rate? What's your cancellation rate? What's your patient satisfaction rate? They ask that on a monthly basis with administrators or practice managers now. So the EHRs can pull specific information, but it's important when you start that, just keep that in the back of your mind. If you want a facility to partner with you, or you go into a facility and express your business and you're in that town, make sure that you can give them what they're looking for. Otherwise, they will not refer to you. Dr. Chen?
Just a comment, be careful of what Alicia said, that what we call geographic creeping. It's 5 minutes. It's just 5 minutes from that house. And before you know it, it's 35 minutes because of the geographic creeping. I know we're mission-driven people. We love what we do. We want to take care of these people, but sometimes you just have to draw the line somewhere and just say, sorry, we can't go there. The other, two other comments I was going to make about, you mentioned assisted living. It is so important for us. One of the front office staff, one of their role is to get the medication list from the assisted living. It's huge, okay? Rather than hunting for the nurse, and you can never find her because she's passing meds. You know, what floor is she on? Third, second, you know, the memory unit. You are walking all over. You're trying to find a nurse. So get the records, get the weight, get the sugar readings from the assisted living. It will save you a huge amount of time. So find out who's going to be that person in your office who's going to request those records. Or is it going to be like what we do in the office? It's a blank sheet. Said, dear XYZ Assisted Living, we are scheduled to see these patients this coming Monday. Please fax over the medication list and the weights and the sugars. So you just fax it over, and hopefully they will. Hopefully you have a good relationship with them, and they will fax the records, the medication administration records to you. The final comment about the number of visits, you can sort of game the system a little bit, in a sense that if you're at assisted living, you can see more patients, obviously, rather than driving 35 miles. So one day you might be seeing more patients because it's an ALF, and then the next day you're seeing less because it's more driving, but averages out to an approximate number at the end of the week.
How lucky we get with getting into EMRs of assisted livings?
Not very good at all. So what I do in reverse is asking them to sign up with Epic as read only. So they will have access to my notes.
But how to get the medication list?
What was that?
How to get the medication list?
They fax it to me.
Right.
Yeah.
So you have no access to that?
No,
Correct.
I don't.
Yeah.
I fax, okay. But this is a separate talk about assisted living and the relationship, how to build that, what constitutes a good relationship and so forth. Because the number 2 referral source for us outside of the health system is assisted living facilities. It's huge. So we need to cultivate that relationship because it's a source of patient referrals.
And I will say consistency and follow-up is key for any assisted living or skilled nursing facility. If you have a provider assigned to an assisted living, they should have a specific date or time they're going to. So every other Wednesday, they're going to that assisted living from 8 to 11. That DON knows. Maybe they can print the list if you have that great establishment with that DON. So creating those roles and responsibilities, not only for us, but for the assisted living, we can kind of push them a little bit too, as long as we're clear and concise with them. I go to specific buildings, specific days, at specific times. I text the DON if I can't, and if they need something right away, they know who to contact. Do you have someone in the office that's assigned to just assisted living facilities and skilled nursing facilities that they deal with, and a person that's just assigned to home healths? Or are they doing everything? As you get bigger, you can actually specialize office staff into those facilities. So when we had a bigger organization with over 3,000 patients, we had a clinical coordinator who's an LPN that just dealt with skilled nursing facilities. She would be on the meetings talking about our KPIs. She would hand out our census. They would contact her if there were any issues or concerns. It was very streamlined, and that's what they're looking for. Route planning, 2-hour time frame is recommended for the patients. They need to at least be up and be able to answer the door if possible. 2-hour time frame gives the provider an allowed amount. Traffic, visit takes too long. You don't want to waste any family's time if they're coming in from out of town or driving to the patient's house. So that's typically what we provide, 9 to 11. Make sure you preference morning or afternoon or evening. Build in time for lunch and breaks as needed. That's hard. Typically the providers are on the go. They're eating in the car, right? But decrease that burden on the providers. What's the number one thing that's difficult right now? Staffing. Keeping staff. So we have to integrate that built-in time for lunch and breaks. Other scheduling considerations, future scheduling. There are technologies out there that you can enter the patient in for future scheduling. Are they every 2-weeker? Are they every month? Do you have protocols on how often you're seeing your patients for home health reasons? Maybe specialty reasons? Are you seeing your diabetics every month, every 3 months? What's your protocol on that? When we switched from fee-for-service to value-based, we switched our protocol for visits. We were seeing palliative care patients every 2 weeks. Not anymore. As their symptoms progress or as needed. Patient calls in, and I just saw them last week, but they're having more shortness of breath. You better believe I'm seeing them today or tomorrow. So that's something that we changed from fee-for-service to value-based. Because we want to have them remain where they reside, at home. We don't want them going to the ER or the hospital or readmitting into the hospital. Confirming with the patient, we talked about that. Accommodating acute or urgent visits. As the organization grew, we actually were able to hire a on-call provider, nurse practitioner. Any patient that called in with an acute issue, she is telehealthing in. Even though it's not her patient, she's remote. It's great. She phoned in, got the patient seen via telehealth. She also handled any urgent concerns or issues for patients. So that way the providers in the field had their base census and they were focused on that and they were able to hit their numbers. Productivity standards is huge. How are you communicating with your providers if they're hitting their numbers? If you're seeing 10 to 12 patients a day, I don't really write how many I see. I see 25 a day, that's my number. I know I need to see 25 a day or 125 a week. So by Thursday I calculate, if I'm sure I see more on Friday, gotta hit your standards, the productivity. Are you bonusing your providers on seeing more patients? Is that ethical? People do it. If they're not hitting their productivity, what are you doing? Verbal warning? You're writing them up? We did. Week by week. If they didn't hit their productivity, first is a verbal. Second is a write-up. Second is a write-up. Third, maybe this isn't for you. Obviously, education. Why are they not hitting their productivity? Time management, traffic. Is their scheduling not appropriate? Sometimes we saw it was the case managers not making efficient routes. We would have to do education with the medical assistants. It wasn't the provider's fault. She was just following the schedule. No-show policy as well. For technology resources, this is just a few of them. For the smaller organizations, we just use MapQuest. Bigger organizations, there's technology out there for geo-mapping. It's a big one, up and coming. Team communication. Providers, medical assistants are out on the road. How are you communicating with them? How are you communicating with your staff? How is that relationship with your staff, front and back office support with the providers? Are you having weekly meetings, monthly meetings? How are you addressing key metrics? Are you reviewing key metrics with your providers? I know for me, I loved seeing it. I want to do better. Are you even telling them what the key metrics are? It's important. Announcements, updates. How are you communicating with your team? Email, text, phone call? Are they checking their emails when they're on the road? If you have a provider that's self-driving, they can't be on their phone all the time. What if there's an urgent issue? How are you communicating that to your providers? Snow is a huge one. Your provider's going out if there's 6 inches of snow or more. We didn't. We switched to telehealth for that day. Safety for providers, number one. Waste identification, recognition. We want to recognize front and back office staff and providers. It's difficult. It's a different field. We're not in a clinic. A lot of these front and office back staff members are remote. How do you build a team like that? Doing Zoom meetings, quarterly events, pizza party. Once a year, I'd throw a huge event, Top Golf, get everyone together. Some of them never seen each other for 2 years, but they talk every day. But no more remote work for our organization. All in the office. Team huddles. That's a great way to get everyone involved quick, 5 to 15 minutes. If you have your practice manager, lead physician, the owner of the company, smaller, larger organization, in person or virtual, preferably in person, or if they're on the road, you got to Zoom in. Talk about productivity. What is today's goals? What is this week's goals? What is this month's goals? And you want to hear from everyone, because we may be doing something that's not efficient, that the medical assistants are seeing, that I'm not seeing. And they typically have great recommendations that work. All you have to do is try. Always have an agenda, typically go off topic. Huddle boards are great, phenomenal, to see it visually. Where are the providers at? Which providers are in certain areas? Who's with who? What medical assistant is with Dr. Chang today? Where is he going today? What part of town? How do I get a hold of him? Does he prefer texting or calling? Those are just things you can include the front and office staff in. On-call schedule for after hours is huge. Value-based medicine, you have to have 24/7 support. Who's your on-call? So your providers. When you're smaller, it has to be. You have to alternate. Who's doing weekends? Every other weekend, one weekend every third week. As you grow, you can have on-call staff that alternate. We had on-call Monday through Friday, 5 p.m. till 7 a.m. And then they would alternate weekends. So they were actually on for 48 hours. Visual Management Board, this is an example. I believe is this Dr. Chang's?
No, it's not my practice. We're
Okay.
not that sophisticated. No.
It is very sophisticated. Looks like they use this for process improvement. Obviously, key metrics are on there. Problems, recognition's huge. Follow-ups, things like that. Any visual cues for the office staff is helpful. Avoiding insufficiencies. Lack of role clarity is huge when we would do monthly meetings with the front office staff. Sometimes as you're growing, things get in the mix, and your different staff members are helping different staff members. Biggest complaint, I don't know my role. I do so much. I do so many different things. What is my role? Having it written down what their metrics are and what they specifically do every day, having that visual representation right in front of them, because if they're going off that, maybe we need to reevaluate some processes or protocols. Referral prioritization, we spoke about that. Common pain points, clinician burden with administrative tasks. I think we're getting better at it as home care providing groups with that support from the office staff, but then we don't want to burden the office staff as well. An effective intake, huge. Talked about the address, contact number. Communication breakdowns. Tell a patient I'm ordering labs. Put the order in. My clinical coordinator never faxed the order. I go back 4 weeks later, lab never came. Got to redo the order. Where was the communication breakdown? I don't know that the clinical coordinator didn't fax it. Did she have confirmation that she faxed it and uploaded it into the EHR? There has to be a trace for every movement, for every staff member. Wait lists. Are you turning down referrals because you're so busy? Can we help them? Can we refer them to a different in-home practice? I know I did. We had to discharge 300 patients for primary care. We divided, referred them to different home health groups and home health companies. There's plenty of us. There's so many patients out there that need help. Effective team strategies to avoid burnout. I'm not going to read line for line for this. Open communication, making sure that Each role is competent. Working from home is great, but are they productive? Are they meeting those metrics? Team meetings, can't stress that enough. And then focusing on efficiency. Pre-visit workflow considerations. Are your providers reviewing medical records prior to walking in that door? Do they know anything about the patient so they're not wasting 20, 30 minutes on things that they could have read in the car? Prioritizing patient needs. I'm in. What am I seeing the patient for? Diabetes? Okay. I'm not doing an annual wellness visit for each patient. Family and caregiver support. I love when family's there. They tell us everything on what the patient's doing. If they can be there within that 2-hour window, we want them there. POA included. And caregiver. Have their medications out. Standard. Every medical assistant or clinical coordinator or provider knows when they're calling, have your medications out. I don't care if I've seen them for 1 visit or 100 visits. They have their medications out. It reduces that time for them calling in for a medication refill. And for the providers, 90-day supply. Narcotics, you should be seeing them every month regardless. Post-visit workflow. For providers or medical assistants who's in the home, do we believe a 90-year-old remembers everything we say at a visit? No, they don't. You want to recap any recommendation or treatment changes. Tell them what you are doing. Are you ordering labs, diagnostics, specialty? When are you coming back? When are they expecting you? Explain everything to them. Arrange. If you're sending a specialty referral to a pulmonologist, where are they going? Are you going to have your social worker contact them and set up that appointment? Is the family going to choose where they want to go? Planning. Tell them when you're returning. Don't tell them the exact date because things change. Tell them weeks. We'll be back in around 4 to 6 weeks. I'll be back around 6 to 8 weeks. Document that in your note. Don't put you're going to follow up in 4 weeks. Then you don't. Your note contraindicates what you just said. Communicate. Provide clear contact information. Do they have a folder? Do they have a card? What is the number to get a hold of you? How does the family know you were there? I always left my card with them. If they were a no-show, I'd put it in their little door, their mailbox. They were everywhere, so they knew. Do you have a folder with your information? We moved on from folders to binders with everything in there that they would need to know. Community resources, who to contact, who's on your care team. Do you have your medication list on there? Height, weight, blood pressure, everything in there.
A couple of quick comments regarding which medical assistant goes out with Dr. Chang. They do rock, paper, scissors and see who loses. In terms of pre-work in Epic, I'm able to do pre-charting. I can open the chart kind of fake, if you will. I can start documenting and chart and order labs and whatnot. That will save me time when I'm there with the patient. Remember, patients want our presence, but they also want our attention. Mm-hmm. They need eyeballs. They don't need eyes on, like when I see my PCP, his eyes are where?
Computer.
Okay, he's not looking at me, all right? Patients need our attention. So I do pre-charting to expedite my work, to organize my thoughts, and to have that connection with my patient, all right? At the post-visit, when I teach a resident, there are all these ists, right? Nocturnalists, sniffists, hospitalists, intensivists. I call it what we do extensivists. We're extensivists. So when I do my note, it's almost like an ICU note. It's from head down to the toe. So when I leave the patient, I literally say, well, we talked about this, we talked about your heart, talked about your lungs, you get the idea. And we're gonna do this, 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 and this. So this way, I'm speaking out loud. They hear what I'm doing or suggesting, and it's a way for me to check in my brain, have I addressed everything? So that's my way of doing things, just a suggestion. And yes, follow-up dates are 4 to 6 weeks. We don't give them a firm date, just like in hospice and palliative care, we tell them what grandma has weeks to months. We never tell, the exact date that grandma's gonna pass away. We give them 4 to 6 weeks because life is fluid. I might not show up on the exact date because I had to go see an urgent patient and so on. Final things for those who are clinicians and whatnot, who are in leadership is really, really important. I know we talked a lot about scheduling and all that, to teach your providers on the management of complexity. There's that burnout slide about competence. Your providers need to know how to handle the top 4 or 5 complex issues that we face at home, right? CHF, COPD, CKD, dementia with behavioral disturbances. Are your clinicians capable, versed in the latest guideline from the Heart Society on the 4 pillars of heart, HFrEF, HEPPEF, HEF, MREF, whatever F that's out there now? Are your clinicians capable of doing this? So that will reduce some of the burnout and stress when you're out in the field alone.
We're going to quickly move on to safety because it's a huge part for organizations, and the number one question that we typically get asked with interviewing or onboarding: how are you or your organization going to keep me safe in the home? What do I need to do? This is a short 2-minute video. There is a form in front of you, just if you want to jot down notes. What you see is good and what you see is bad in the video as far as safety.
Meet Nora, a nurse practitioner who's on her way to a home care visit with Sylvia, who lives in a rent-controlled 4th-floor walk-up apartment. Nora's getting ready to leave for the appointment. She takes some cold medicine before she goes. She has a bag with her tablet PC and charger. Here's her box of supplies. After packing up her car, Nora checks her navigation app to remind herself where she's headed. Then she checks the weather app. She text messages Reg, the coordinator at the office, to let him know she's getting on the road for the day. There's no response, but Nora heads out. Here's Reg with a text message response.
Hello, Tony. This is Nora from House Calls. I just wanted you to know I'm about 5 minutes away. Can I ask you, Tony, to make sure that the cats are secured in the bathroom before I arrive?
Thanks to Reg's message, Nora avoids the accident area and arrives at Sylvia's on time. She parks in the first available spot since Sylvia's street is usually tough for parking. Nora's phone shows it's 8:20 a.m., so she thinks she can be out of the spot before 9. Nora gets out of the car quickly so she won't be late. She gets all of her bags onto her rolling cart. She places her phone and keys in an accessible pocket. Her shoe covers go in her other pocket. It's a quick walk to Sylvia's building. Sylvia's stairwell light is out again. Even though Nora's been to visit Sylvia before, she shows her badge before entering the apartment. She also pulls her shoe covers out of her pocket and slips them on. Sylvia's daughter wasn't able to get both cats into the bathroom. At the end of the visit, Nora goes through her mental checklist to be sure she's repacked everything she brought. It all goes back on the cart so that she doesn't have to struggle down the stairs. Sylvia's daughter, Tony, grabs a flashlight and escorts Nora down the stairwell. After Nora leaves Sylvia's, she notices her cell phone is below a 50% charge. She pulls her car charger out of her glove box so she can charge on the way to her next appointment. She remembers to text Reg before she starts the car.
Does anyone have any notes down for what she did good in that video? There's a few. Checking the weather. Arriving to the appointment. Communication. Excellent communication in that video. Anything else? Charge her phone. Has access to phone, keys, shoe covers even. That's nice. Don't forget the equipment. Key. Now, there were a lot of not so good things that Nora can improve on. In our organization, we provide supplies once. If they lose it, we will replace it. If they lose it a second time, they have to buy it on their own. A lot of not so good things that Nora can improve on. Anyone? Texting and driving. Parking. She's going to get towed or a ticket. Providers pay for their own tickets, or a medical assistant pays for their own ticket. We don't pay for it. They should know better. That one. Why is she wearing that?
And driving a nice convertible.
Flashlight. Every provider should have they have that on the phones, the little flashlight, or you could bring a mini flashlight. The cat. Pets need to be put away. If I hear them, I will wait and call the patient and ask again if they're put away. You never know. I would have filled it. That's me personally. Some people like driving when it's almost close to E. Nope, not safe, especially in the winter. Biggest take back, observe. If they're new grads and we're training them, how long are they going out with the provider? Right, do you have a checklist? And if they have to pass an orientation checklist, we do. Otherwise, they can't go out on their own. You have to look at your surroundings. Who do they call an emergency? Do you have a code word with your medical assistant? Are they calling 911? Are they calling the office? What if they're in a true emergency? And do you have a dismissal process in situations if the provider is unsafe? Like I said, our organization, if they feel unsafe, they can leave at any point. They can follow up with the phone call. Never going back? Discharging. So we have a discharge protocol. Yep.
What's the trigger?
Any abuse, so obviously verbal abuse, physical abuse, if you got to call 911, if they broke pain protocol, anything like that. And our discharge process is we give them a 30-day supply of medications. We send a referral to a different program or go back to their PCPs if they can get to it. And they can still call us if they have any urgent issues where we can coordinate their care, not treat it.
What about things that are not directly related to the patient, like caregivers, drug paraphernalia, like clearly, like stuff? We're not talking about involved.
Yeah, that's up to your practice to develop a protocol for that. I will say if I feel like a patient is not taking their pain medications appropriately, I'll get a urine, see if it's in their system. If it's not, I'm discharging you immediately. It's in our pain contract. If it is, then we talk to the caregiver, see who the POA is, do a care plan meeting with a social worker on the phone, and then based on your findings and your intuition as a provider, you come to that decision.
It's not patient's fault. Patient's fine. It's the family, the caregiver. So when the environment is questionable, patient is fine. Patient needs care. But at which point you say we can't provide our provider's safety is more important.
That's based on the provider. Some providers feel okay, they feel safe, they want to continue. Other providers may not feel like it's appropriate for them to go back. So that is a provider case scenario, case by case, and the situation on what's going on. But safety is always number one, for sure.
That's a huge point. We work with caregivers. I tell them it's a dyad, it's a pair, it's a team. A relationship has to exist that way. You're absolutely right. The patient is very nice, demented and whatnot, but the son, this happened 2 or 3 months ago, completely inappropriate, obnoxious, offensive, calling me racial this and that, and he was dismissed. But the patient really wasn't involved. He was just a nice, demented guy. But the relationship exists because the patient has dependency on the caregiver to provide the care, and he is the agent through which the care is delivered. So I say, the relationship is broken down. You call me all kinds of nasty names and so on. So we dismiss from the clinic, from our practice. You have to think about dismissal for non-adherence. That's a tricky one. Just because the patient keeps smoking, is that enough for you to dismiss? The same would go if the patient doesn't take the medication. and keeps calling you and heart failure and whatnot. Is that time for dismissal? That's a little bit more murky one.
All right, well, thank you very much. We have just a few closing announcements at this point. A reminder about our March 7th session. You're invited to come back here at Thursday, March 7th, 4 to 6 p.m. We'll be talking about value-based care and specifically contracting with payers to demonstrate the value of the care that you are already providing. I want to extend our thanks from HCCI to Alicia Boback for leading this session. Thank you so much. And of course to Dr. Chang for your input, as always, and expertise. Thank you so much.